Okay, thank you. Okay, so for those of you who are here, the sign-in sheet is located here, so you guys can just sign in. Also, the handout here is something from Student Services, and it's basically a test anxiety workshop that they're doing next week, I believe. Just keep in mind that Student Services, they always have different workshops like this. And just to kind of give you, since we're talking about test anxiety and testing, just a few tips that I can give you for testing for patho. So with our course, as you guys know, all of our tests are multiple choice. We do have some selected all the applied types of questions. Those questions, just keep in mind, they're either all or nothing, so there's no partial credit with those questions. A lot of times, students do have challenges with those questions, and so the best way to take a look at it is kind of working the question backwards, in a sense where you're going to look at the answers first and then see if each answer correlates to what the actual topic is in the particular question. So that's the best way to take a look at it. And I used to do this also when I was in school, is actually go through each answer, kind of write out, okay, information behind that answer and see if it correlates to what the question is asking. So sometimes we just write it to the question and just kind of start brainstorming from there, but you want to look at the answers and look at that in more detail, okay, if that makes sense. Also, just to give you a heads up, our select all of the applied questions are pretty much going to be focus based in a sense where it's either like a list of risk factors or a list of signs and symptoms or a list of, you know, pathogenesis type things. So as you're studying your information, and if you, as you guys are making outlines, you may want to make a list of, you know, items that, you know, have like a number of things for risk factors or a number of different types of signs and symptoms, because the select all of the applied questions that we have in our course are going to be focused in that manner, okay? Now, when you get into nursing core, that's a whole different situation, because your select all of the applied questions get more challenging and you know, a little more NCLEX style, so they'll get into that. But again, I just wanted to make everyone aware that there's no partial credit with those questions, and it's either you get all of them right or none at all, okay?
So it's like select all of I won't be there, like what you're talking about.
Yeah, so what I was going over was how to answer select all of the applied questions.
Okay.
So when you do answer those questions, sometimes people figure that they can get partial credit, but there's no partial credit with those questions. It's either all or nothing.
But it will be obvious if it's like more than one they want us to select. Right?
Yeah, it'll say that in the title of the question.
Okay.
Yeah. So I think you guys had some of those already with your check your understanding questions, and I can't remember if it was on the first quiz or not.
Yeah.
Yeah, there's like 20 questions. I was expecting 5.
Oh, yes, yes. No, we usually have about 20 or more questions on the first quiz. Okay. Okay, so I just want to get started and dive right into the topic. So this upcoming week, yes, we have 5 chapters. I know it's a lot of information, but just keep in mind chapter 10, 11, 13, 14, and 15. Chapter 10, I'm going to get started with this particular chapter because I feel it's really quick, easy. I just want to show you guys a technique of how to study this information and memorize it, you know, and it'll be 1, 2, 3. Okay. So when you take a look at chapter 10, it's broken down into different hypersensitivity disorders. So overall, just to kind of give you an understanding, what is a hypersensitivity disorder? This is basically when the immune system comes into contact with something, and we don't want to say exactly foreign, but I guess we can use that term. But there's some sort of contact with something in the environment or whatever the case may be, that's now going to cause the immune system to undergo a reaction. Now, in most cases, this reaction or this immune response is now going to bring out a particular reaction or signs or symptoms that lead to like a really, you know, type of condition that follows. So I want to make sure that you know these particular types because it's going to come up again in most of our classes, or I should say most of our topics that we're going to see in the future. So the best way to tackle this information, I feel, is to make a chart. And you can make a chart I know the last few slides or the last two slides have their own chart, but I think making a flow chart with this topic will actually make things much easier for you. So with our chart, you want to break down the different types. The first thing that I told you guys is really important to know is making sure you know which cell or immunoglobulin, or I should say antibody, excuse me, that's actually part of this situation. So we can just put here cell, okay, slash antibody. So then you can put for each one which cell is mediated, okay. Now, keep in mind, and I think we all know this for, if you guys looked at this information already, the first three do have involvement with the Igs, the immunoglobulins, okay? Whereas 4 stands out, and this is what we call T-cell mediated. So for those of you who are color people like myself, when you're making your flow charts, you want to make sure you color code things that stand out. So this one definitely stands out because this is going to be T-cell mediated. So it stands out from the rest. As you study information this way, when you get to the test question, you already know. Okay, type 4 is going to be T-cell. Everything else is going to have some sort of immunoglobulin involved with it. Okay, whether it's E or M or G or whatever the case may be. Now, the next area that's important to pay attention to is what we call the mechanism. So the reason why we use the term mechanism here, because it's not an exact pathogenesis, because it's not a disorder, it's just more of a category here. So we're explaining what is the exact mechanism that's happening with this particular type of hypersensitivity. So for type 1, just to kind of sum this up really quickly, these patients are exposed to whatever the allergen is, okay? Once that antigen gets inside the immune system, it recognizes, okay, hey, this is foreign, it shouldn't be here. Mast cells are going to be released. Immunoglobulins, IgE, are also released, okay, part of this process. Histamines are released once mast cells degranulate. They start to have vasodilation with the vessels because of this whole process. But then now the patient's signs or symptoms do also start to develop, like any type of itchiness or sneezing or things like that that go along with an allergic reaction. So that's kind of like explaining the mechanism, which is listed in here, okay? So when you see the breakdown of what's happening at the cellular level, that's going to be considered your mechanism part. So that's the part you want to put here in your chart. Now, how you break down that information, you know, whatever works for you. So sometimes people like to write it as paragraph forms, or sometimes people like to write it as a bullet point. So whatever's easier for you to memorize. I know a lot of times people memorize bullet points better, okay? So you'll save some space to kind of make that area. The next thing that I would also take a look at is the time frame. Okay, so each hypersensitivity disorder has a particular time frame attached to it. And just to make you aware, the time frame is usually associated with the entire time frame it's going to take this reaction to develop. Okay, so for the first one, they have 15 to 30 minutes, which means that from the time of exposure to whatever the allergen is, okay, whether it's the dog or the smoke or whatever the case may be, when the person comes into contact with that allergen, it's going to take about 15 to 30 minutes for this mechanism to develop. And the patient will start to have signs and symptoms from there. Okay, so that's how we want to look at the time frame. And then the very last item here are examples. So under examples, please make sure that you memorize the examples that are listed here. I will tell you right now for type 1, type 1 is usually the most common type of hypersensitivity that we have, okay, out of the 4. And one of the reasons why is because it is associated with allergic reactions. When we talk about allergic reactions, it's not always cases where, you know, people have food allergies and things like that. But this definitely falls under the category of where your patients have drug reactions, okay? Please make sure you know that as an example. They do believe that that's one of the most common examples for type 1 hypersensitivity. And if you watch the video, I don't know if I told you guys what happened to me as an example. So I found out in the ER that I was allergic to morphine. Okay, so sometimes your patients will find out, unfortunately, that they're allergic to certain medications. And so when there's those types of situations, they fall under type 1 hypersensitivity, okay? And that's something, unfortunately, that is very common. It's gonna, you're gonna see this, I'm sure, time and time again. Okay, so that's how we wanna work it, okay? And again, for the visual learners, for those of you who are really do well with color, you wanna make sure that you color code the areas that stand out, okay, for your chart. And if you have or make a chart like this for the hypersensitivity types, I feel you should be good to go, okay? The information is straightforward, not a problem. Now, the last two slides I have here are charts that are already made up for you. So if you want to use those or maybe make your own and just kind of add it in. So these are just examples, but this is not set in stone. You don't have to use this. This one I like because it has a mnemonic with it. One thing I just want to point out, if you notice, latex allergies fall under type 1 as well as type 4. That is true because latex allergies, it just depends on how it reacts in that person. It can be one or the other. Sometimes it can be a delayed hypersensitivity, or sometimes it can be a situation where they do have more of an anaphylaxis where when they inhale it, and those are more kind of like the severe ones where people can't be around any kind of latex, and when they inhale it, it causes all of that type of, situation. Where some people, they can just have more of like a contact dermatitis where they can't touch it or wear latex gloves. Okay, so that kind of falls in that region. So I just wanted to point that out. But everything else, I think you should be fine. So does anyone have any particular questions on any hypersensitivity type that may be confusing? Yes.
I just wanted to clarify for the mechanisms part of the tables. You said that it's more like the stuff that's released.
Yes, so let me go back to one just to use that as an example. So, and I don't like this board because I can't highlight it. So say for example, starting here, the reaction is initiated by the IgE. Well, the IgE, you'll put this here as well in the type. Okay. But just explaining to like these 3 sentences in here, or 4. So explaining that the mast cells are actually going to bound to the antigen when they cross-link IgE receptors, and then now mast cells degranulate, they release histamines, leukotrienes, and so we know the chemical mediators that are released, and it causes now vasodilation, hypotension, okay? So that's basically kind of like all the things in the mechanism, okay? Thank you. So that's kind of explaining, another way you can look at it is explaining like the pathogenesis, like the process of what's happening in the body. But we use the term mechanism just for this category. Yes?
So you want us to focus on the examples that are in the slideshows, not like the one on the last two?
Yes, focus on the ones that are in the slides here, because that's straight from your textbook. The last 2 slides with those pre-made charts, I just found that on the internet somewhere, just to kind of give you examples of how to make charts. The information in there is pretty solid, but I would say focus on just what I have in the PowerPoint. Okay, any questions from the hypersensitivity types? Okay, and just keep in mind, I will be, you guys know I do 2 tutoring sessions, and then we'll also review again, so we'll get into definitely more detail right before the quiz next week as well, okay? But because of our time, I just want to show you how to study and things like that. Okay, so we know what to do for chapter 10. Now let me get to chapter 11. So on the outline that I provided in class, we know that chapter 11, I wanted you to pay attention to the first 12 slides, and then starting slides 13 forward, you can use the PowerPoint slides or use the flow chart, okay, that I gave you. So a lot of times students like to use the flow chart, that study guide, because it's a little easier. It's already laid out like this basically for you, okay? So, however, I do want to spend time for this chapter and kind of go into a little more detail with the first 12 slides, because this is solid information that we need to know across the board for leukemias and lymphomas. And I do want to explain some things because some of this pulls out a little bit of anatomy and physiology as well. Okay, so number one, oh, and I'm sorry, let me just backtrack to something I want to make sure you know. Make sure you know for the hypersensitivity types to know not only the number but also the full name. Okay, because on a test question I could put either the number or the full name. So just make sure you memorize both, just in case. Okay. Now, for chapter 11, one of the first things that we should know is how to define the difference between a leukemia, a lymphoma, and then we also put plasma cell myeloma in a class by itself. Okay, so a leukemia is a cancer of a white blood cell that is circulating in blood and bone marrow. Okay, so that's basically the definition of that. A lymphoma is a description of where we have a cancer in a white blood cell that's circulating in lymphatic tissue. Okay, so lymphatic tissue, lymphoma, leukemia, emia, blood. Okay, so this is going to be cancer of white blood cells in the bloodstream. Okay, so the name correlates to the location. Okay, so that's key. Now, when we say plasma cell myeloma, they do kind of put this in a class by itself here, along with, what's the other name for it? Multiple myeloma. Okay, so it has two names. However, this is also a cancer or malignancy of a type of white blood cell, but in particular a B cell, a B lymphocyte, okay, in particular. So the reason why this is in a whole different title, okay, is because this particular cancer does behave a little differently than the others. And I always tell students no one should get this question wrong in the test, because multiple myeloma really has a lot of different characteristics than the others. Okay, so once you memorize it, you'll know it. Okay, so that's that. Now, the other thing that's important to know, and I'll start here and then I'll go to the chart. When we talk about cancers, leukemias in particular, white blood cells, I think we know from anatomy, they are divided into granular sites and agranular sites. Okay, so your granular sites are going to be your fill family, your eosinophil, neutrophils, basophils. Your agranular sites are going to be the site family, so your monocytes and lymphocytes. So it's important to know the two categories. The reason why this is important to know this information from anatomy is because when we classify leukemias, they do have a particular classification, okay, for, you know, whichever white blood cell is attacking, okay. So the myeloid lineage, and this is also from anatomy, the myeloid lineage will give rise to red blood cells, platelets, and monocytes. Monocytes, remember, is part of the site family, or a granular site, and granular sites, excuse me. Lymphoid lineage are going to be B cells and T cells, okay, and natural killer cells. So anything that's a lymphocyte is a lymphoid lineage. Everything else is a myeloid lineage. So that's the easiest way to memorize it. Okay. So lymphocytes we know break down into B, T, and natural killer cells. Yes, from anatomy. Okay. So anything that's a lymphocyte, lymphoid lineage. Everything else, okay, will be myeloid lineage. So even a granular sites, okay, which are your phils, eosinophil, basophil, neutrophils, and then the monocytes Okay, even though they're the agranular, they fall under myeloid. Okay, so this is just memorization. Now, the reason why we want to understand this foundation is because it's going to come up when we start looking at the different leukemias like a CLL, a CML, ALL. Okay, so now when we see these abbreviations, now we have to figure out what's happening. Okay, so this picture I like a lot because it shows you the stem cell, okay, because it's one main stem cell that gives rise to everything, and it breaks down the lymphoid and the myeloid, okay. So what you should know here, very important, and this goes back to anatomy as well, anything that's a lymphocyte actually normally flows through blood and lymphatic tissue, okay, which means that any of these cells, depending where the cancer is located, can give rise to a leukemia or a lymphoma. So if a person has a cancer attacking a B cell, and that B cell happens to be in the bloodstream at the moment where the cancer's, developing, that person has a leukemia. If that person happens to have a cancer in the B cell that's now developing in the lymphatic tissue, then that is how we classify a lymphoma. Okay, so the terminology just correlates to the location of where the cancer is happening. Are we good with that? Okay. So that's for the lymphoid. The myeloid cells, okay, which we know are everything else, they only flow through bloodstream. So they are only going to give rise to leukemias. Okay, only give rise to leukemias only. Now I'm going to erase this because I want to show you something else. Okay, so we have a stem cell. Okay, really big, and it's going to give rise to, it goes through a maturation process actually, to give rise to a mature cell. Okay. So you know how in chapter 1 we discussed the term acute and chronic, and acute being a situation where the disease process is aggressive and it's developing really fast, whereas chronic it takes a little longer to develop. Okay, so that same concept does correlate to when we discuss acute and chronic leukemias. However, it is a little additional thing to it, in the sense where when we're going through the maturation process of a cell, okay, we know that there's several levels. Okay, the level here of immaturity, and we're going to call this the immature phase. This is also known as the acute. Okay, so this is also known as the acute phase. So anytime we have the immature process, because these cells are immature at this moment, they're not mature yet, so they're still developing. But if a cancer hits at an immature stage, this is definitely considered an acute cancer for leukemias. Just as a side note, and this will help you for the leukemias in the future, acute leukemias are very aggressive. The signs and symptoms are abrupt. Okay, so these patients have signs and symptoms immediately as it develops. They can get very complicated to the point where they have a lot of bone marrow suppression, a lot of infections. Even in your textbook states that patients that have acute leukemia sometimes die from the infections because the infections are so aggressive. So the point I'm trying to make here is that acute leukemias can be very aggressive. Okay, so you want to think about this. The cancer we know is bad. It's an alteration in the gene process of a cell. So the cell, because it's now in its immature phase, is going to start this altered gene process here and not even wait till it gets here. So that's telling you how aggressive that cancer is, okay? And so this is what we call the acute phase, or the acute portion of the leukemia or lymphoma. Now, they also have another name for this. Another name, just in case if you see it, is called the blast stage. So they call it the acute or the blast stage. So just in case if you see that terminology, it means the same thing.
Would that be where you get acute lymphoblast?
Yes, yes. So when they say acute lymphoblast, it's because at this region, it is it's leukemic. Okay, so there's cancerous.
Right? Isn't that the most severe leukemia also?
Yes, yes. And so just to make you aware, what happens is this: when they take take a sample of the blood, they're looking at these cells under the microscope when they do a peripheral smear. If you see immature cells on the peripheral smear, you may see, okay, here and there, okay, but mainly we're supposed to have more maturity in our blood than immature. Blood cells do have a high turnover rate. However, if you see a lot of immature cells that now look a little strange, okay, in the sense where their genetic material is different, and then now you have a lot of immature cells that are clustered together, okay, that's a telltale sign that cancer is occurring, because immature cells usually don't group together like that and hang out together. They're kind of here and there doing their own thing, okay, as they're, turning over. Some cells turn over 60 to 120 days depending on the cell. So, they're kind of here and there, sporadic. But when they're all clustered together, and this is how they diagnose it, that's not a good thing. So that's where the term lymphoblasts come from, because they see, okay, these are lymphocytes, but they're in their blast stage and they're clustered together, okay? Which is one of the reasons why I left the pictures in there for you in the chart, so you can see what that looks like.
So in normal blood, there will be like immature cells, but there won't be like clusters.
Yeah, you may see like sporadic here and there,
but mature would be more.
Yes, you would see more maturity.
Like in anatomy where we saw the blood.
Yes, you'll see all mature cells, and I'm quite sure even when you looked at some of the peripheral slides in anatomy, you saw like a little something that looked a little weird or strange, and you just kind of bypass it. But that was kind of more explaining like an immature cell, or maybe a cell that was on its way, finishing, so now we can turn over to another cell, and that's normal. However, when you see a lot of cells that are in their immature stage kind of clustered together, that's not a good sign.
So it's obvious. Okay.
Yes, it'll be obvious on the microscope. Okay. Now, when we get to the mature phase, and so let me put this here. So tired. I was up last night. I had to help my neighbors, and I was at Kaiser emergency room all night with my neighbor. I had an issue. But anyway, mature phase, also known as chronic. Okay, so this is where you have the cancer now attacking, okay, the mature phase of the cell, and this is another term we call for this stage is chronic, okay. So, not to say that this is better, okay, we know that it didn't attack all the way up here, okay, but it kind of waited until it became mature and then, did the turnover there. Chronic leukemias and lymphomas, the signs and symptoms are not as abrupt as acute. So even one example that we take a look at is CLL, I believe it is. Sometimes patients don't even know they have it until they just go for a routine blood work, okay? Because the signs and symptoms are not that abrupt. But unfortunately, they find out kind of just, I don't want to say by accident, but pretty much, okay, they find out. So when you have a disease process that kind of takes a little longer to kind of, develop, you may not see signs and symptoms immediately, with chronic things. But that doesn't mean that it's, a good situation. And just a side note, we're going to cover later on occupational lung diseases. And occupational lung diseases take a very long time to develop. Okay, years to develop. But now, once we finally have a finding and say, oh yeah, you have occupational lung disease, there's no turning back. Okay, so just keep that in mind. When it's chronic, it does not always mean that that's a better situation. Just to go back here really quickly, just to make you aware, and I believe I said this in the video, when we have acute leukemias, as you can see, there's a lot of different levels, and I just put 3 here, but obviously there's a lot of different levels of the immature phase. Depending on what cancer, if it hits at this immature phase or this one or that one, they all have a different subtype or a different name. I am not going to hold you responsible for memorizing all the different subtypes, but I just want to make you aware in case you do see this in the future. They do have their own names for each subtype. And the reason why I'm stressing that is because some subtypes are more curable than others. Okay, some subtypes are, okay, and I don't want to use the word cure, but you know what I mean by that. But some subtypes have a better prognosis, okay, than others. That's the best way to say it. Okay, so we're good here. All right, now, what else do I want to say? It's 2:30. And just to make you aware, I'll just go with the flow, depending on if the other group is going to come at 3. If they don't, then we'll just continue. Okay, so 4. But I have to leave this room at 4 because there's another class coming in. Okay, so there's a chart just kind of going over acute, chronic. Okay, so some characteristics. This slide, and I keep forgetting to change this. We don't have a known cause for cancer. So we can't say, oh, we have a known etiology. No, we don't. We have risk factors. If we had a known cause for cancer, we would have the cure for it. Okay, but we have possible risk factors. The risk factors we listed here are some possible viruses. I went into those in the video. Radiation exposure, chemical exposure that can have some damage to the cells, okay? One thing that we definitely know, and just to give you an example, I went to, I had a dental appointment last week, and I had to, have some x-rays done, and what is one of the first things they give an individual when they have x-rays? A shield, okay? Why? Because radiation exposure can damage cells, okay? And it has definitely been proven to know that, okay? I know that's contradictory to radiation treatment, okay? However, we know that radiation treatment is used for those particular types of tumors to, kind of be more focal or localized to that area. Here, when we're taking x-rays, we don't want to blast the entire body, okay, with radiation. Okay, so we know that part. This slide focuses on the most common signs or symptoms that you'll see across the board with the different leukemias and lymphomas. This same information is sort of plugged into that spreadsheet that I provided where I put the items that are in green, the shared signs and symptoms. So it's, that piggybacks with that. How do you diagnose a blood cancer? Blood work. Okay, so that should be plain and simple. So what we look for in the blood work, very important to know. Number 1, as they have here, neutropenia. Why neutrophils? Neutrophils, I think we all know by now, are the most abundant white blood cells circulating in the bloodstream. Okay, what's the reason why they're the most abundant? Well, they're pretty much our first line of defense cells. Okay, so keep in mind that even if a person has cancer, and we know that cancer is doing a lot of damage, okay, to the cells, your immune system will try to fight it. Okay, so your immune system will recognize it. It'll send over neutrophils. They're the first ones. They'll try to do something. However, the more specific types of cells that will help are T lymphocytes. T lymphocytes are the ones that really help viruses and cancer-infected cells. Okay, so I just want to, as a side note, make you aware that the immune system is still trying to fight. Okay, It doesn't completely win the battle, but it tries, yes.
Do we need to know like the exact number?
No, you don't need to know the numbers. We're gonna incorporate numbers in our class activities, okay? And I'm glad you brought that point up, and I just want to say this, and I'll have this on camera as well. In the videos, if you see me, because I posted my older videos, if you see me discuss the lab values and kind of go over that in the videos, I did post, and let me show you where it's located. If you go to your Blackboard and go to instructor blog where I post the videos and PowerPoints, I did post a clinical reference guide here, okay? So if you open this, it's a PDF file, and it basically has all the labs, you know, and numbers, and it's broken down into different sections like lipid panel and CBC with diff and all that. So if you need to reference something, you know, just kind of looking through the PowerPoint, if you're reading something in the textbook, you can reference this here, okay? But just keep in mind for test purposes, I am not having you memorize the numbers. I used to do that in the past, but I feel like you guys have enough going on. The numbers you're going to see for the rest of your life, so you'll know the numbers. But I just want to make sure everyone knows which labs will be associated with which conditions, okay? So, again, as a side note, when we have our in-class activity next week, we're going to have an in-class activity on, you know, leukemias and anemias and things like that. And so we're going to start with the CBC. So we're going to use that part of our assignment. So we'll go over like what the numbers could look like if a person had this type of condition, okay? So you have that reference. I would say keep it, because a lot of times I, you know, see nursing students that always come back and say, oh, do you have that handout? And, you know, so it's a good reference to keep, okay? So that's that. Another thing, looking at the peripheral smear. So when blood is taken, yes, we do look at the lab numbers, okay? So how many white blood cells do they have, how many red blood cells, and all that. But now we must also take a look at what do these cells look like under the microscope? Because remember, in anatomy, you guys looked at the normal histology of blood. In this situation, when we're looking at the histology, unfortunately, it's not normal, okay? And so now we are looking at the difference, okay? And seeing that these cells are maybe larger, maybe they have 2 nuclei, maybe they have, you know, they're all clustered together, and they're all immature, you know? So there's some sort of change that is identified here. That's important to know, because this is how they diagnose it. The most definitive diagnosis is taking the blood work and also taking a biopsy. If it's like a lymphoma or whatever type of tissue, bone marrow, they can go right in. That's the most definitive, and that's how we want to diagnose this, okay? Not just based off of signs or symptoms, okay? So that's that. This goes into the treatment and protocol, and so just to kind of sum this up, if a person has a leukemia or lymphoma, blood lymphatic cancer, it's not just a cancer that's localized to, let's say, the brachial artery in the left arm. This is now a blood cancer that's systemic. So what is the best course of treatment to attack a cancer systemically? Is going to be chemotherapy, okay? Chemotherapy will attack systemically this cancer, okay? Now, we know, unfortunately, the downside of that, okay? So it's attacking rapidly dividing cancer cells that are happening in the patient's bloodstream, but at the same time, it's also attacking the rapidly dividing normal cells, blood and epithelium, and then causing, you know, those problems. But I just want to make you aware of the reason why they use chemotherapy. Even if they want to do a bone marrow transplant, so in some cases, certain leukemias in particular, like multiple myeloma, or I think CML, can't remember, no, not CML, but there's others that they would prefer to do a bone marrow transplant, okay? And if you look at it, you're basically giving the patient nice, healthy bone marrow tissue, okay? So now they can have some more healthy cells to attack this disease. The problem here, or I shouldn't say the problem, we want to make sure for protocol purposes that these patients have chemotherapy done first. Please make sure you memorize this. This is the order. Because we don't want to go in, okay, get this patient in, give them nice healthy bone marrow tissue so they're good to go, in a total leukemic state. That's not a good idea. So we want to make sure that they have chemotherapy performed first to kill as many rapidly dividing cells before we actually now introduce bone marrow, nice healthy bone marrow tissue into this patient. Okay.
Could
So-
chemotherapy alone cure it without bone?
Yes, it can. So some cancers, and it all depends. So just keep in mind, as far as treatment or management for, these types of cancers, it all depends on a lot of things. The stage, how aggressive it is, the extent,
So when chemo doesn't work, but you have given it already, that's when bone.
Not necessarily. It depends on the cancer. So the oncologists know that some cancers will react better to having a bone marrow transplant. So they just like automatically, will try to set that up. But what I was trying to get at was that they'll do a round of chemo, and I'm going to say one round, but they'll do chemotherapy first before the bone marrow transplant. But it all depends. Chemotherapy can help with some cancers. Let's say, for example, hairy cell leukemia. So hairy cell leukemia is a cancer that it's chronic, but it tends to be respond okay to chemotherapy. Okay, so they don't really have to go through the route, most likely a bone marrow transplant. So the chemotherapy alone usually is okay for that. So it just depends on the cancer type. Now, saying that, and let me just say this thing. Radiation and tissue-specific type drug therapies are used for some cases, and we're going to say more so for localized tumors that are like lymphomas. So if a patient has a lymphoma, let's say the lymphoma is just like, in the stage 1 or something, and it's just localized to the cervical region, that patient may not need a full round of chemotherapy, okay? They may just need radiation just for that area, okay, to kind of shrink the tumor, see what happens, okay, then they can just take it from there. So I just want to make you aware they do have different types, it just depends on the cancer. Now, the purpose here of cancer treatment overall is to make sure this patient goes into what we call a complete remission. What is a complete remission? This means that these patients have no more cancerous cells in the bloodstream, everything's wiped away, and we want to make sure that there's no more bone marrow suppression, meaning that the white blood cells are back to normal, the red blood cells are back to normal, platelets are back to normal. So now when you have the labs performed, when the lab report comes back, everything should look nice and clear and normal and healthy. Okay, so that's what the goal is here. However, it is important to know that when patients have a leukemia, they will, and I don't know the exact protocol here, okay, for how many rounds or cycles, but they will be required to continue their chemotherapy cycles, and they say for up to 2 to 3 years after a complete remission, okay? And you're probably wondering why. Why would they need to continue if everything looks good? Well, as we said earlier, and we know this from anatomy, blood cells have a high turnover rate, which means the patient can be discharged, let's say Thursday, everything looks great, good to go, it's under control. But who's to say now next week, when now we have another maturation process coming down the line, who's to say that now this genetic information is now going to start to turn over again? And now we're going to continue to have another leukemic cell come down the line. Okay, so this is the reason why they continue chemotherapy. They want to be a little more proactive, okay, when it comes to this situation, so we don't continue this patient, or easier to manage this cancerous state. Okay, does that make sense? Okay. Are you guys here for the 2 o'clock tutoring or the 3 o'clock?
3 o'clock.
Okay, so I'm still on the 2 o'clock topics. Okay. All right, so that's that. So for, yes,
Sorry, do bone marrow suppressions, like in the blood, is it just for leukemias or any type of cancer?
Any type
will
of
show up?
cancer.
Oh, okay.
yeah, any type of cancer can have bone marrow suppression,
Okay.
but definitely more so with the leukemia, because that's where the cancer is kind of happening. So they're going to be a little more prone to it for sure. With other cancers, like organ cancers, they have bone marrow suppression that starts like as the stages get higher. You know, in the stage 1, it may be a little bit, but it definitely becomes more prominent as it progresses, and you know, there are more metastases and things like that. Okay, so the rest of this goes into the different types of leukemias and lymphomas. So just to make you aware, the spreadsheet, and I'll just go right to the spreadsheet because that's a little easier to handle. Oh, what happened? Where'd it go? I don't know what happened to the spreadsheet.
One of the tables of diseases.
Yes.
It's on the week 2. Oh, yeah.
What did I?
Your week
Oh,
2.
okay, I'm sorry. I downloaded, I forgot that I
Right there.
Yeah, I forgot I did the download. Okay, so again, with this spreadsheet, this should be easy for you to memorize, okay? So let me tell you how to tackle this. When you're memorizing this at home, make sure you focus on obviously the title type. We already know just from understanding myeloid, lymphoid, what types of cells could be involved. Just to make you aware, if it's a myeloid type of leukemia, the most common cell that it could attack is a neutrophil. Okay, neutrophils are usually the most abundant, you know, in this situation. If it's a lymphoid leukemia, the most type of lymphoid cell is usually a B cell. Okay, but that's just more common, but it could attack obviously any of the others. Okay, and I think I already said this in the video, but I'll say it again here for tutoring. If any time a person has a leukemia of a T cell, not a good prognosis. Okay, T cells are actually the cells that attack cancerous cells, and you want to look at this whole premise almost like HIV. Whereas HIV attacks a T cell that's supposed to attack the virus. It's the same situation here. When a person has a cancer in a T cell, not a good prognosis. Okay. So anyway, going back to this, I put the percentages here. I will never test you on the percentages. I just put them there just so you'll know, okay, which ones are kind of more common than the others. Okay. The age range here will help you possibly for some case study type questions. So in a case study question, we'll have, okay, maybe a 50-year-old male or a 5-year-old child or whatever. So that will kind of help you navigate what could be associated with what. Acute chronic, remember, I will not test you on the pictures, but I just left them there for people that are interested. It is important to know if it's acute or chronic, and we know what's happening with that. The items that are in red are definitely hallmarks, things that stand out. So it is very important to memorize those. I guarantee you, you're going to see a hallmark in a test question because that's the only way that I can provide you the information to know what's going to stand out for that particular cancer. Okay, so I can't have a test question and say, oh, well, this patient has fatigue and bone pain and weight loss. Tell me what type of cancer it is. Well, that can be any cancer. Okay, so we have to zone in on the things that stand out. Okay, so I would say look at the items in red as well as black. Okay, and the ones that are in green we know are shared signs and symptoms. And so if you know one, you know them all. And just to also make you aware, I do not have a lot of test questions on treatment for cancer. The reason why, what's the treatment for leukemias and lymphomas? Chemo, bone marrow transplant. Okay, so it's not anything, you know, saying, oh, well, ALL is going to have this totally different treatment and CLL is going to have this totally different treatment. It's, you know, across the board it's the same. So we don't have to spend time on that. Okay, so that'll save you some study time here. Okay, because I'm running out of time, I need to rush a little bit here just to finish this up. Oh, what did I do? So for 13, let me just show you something really quick to help you. So as you see, I'm giving you ways to study. So for 13, this chapter focuses on anemias. So for anemias, we have several different types. When you're studying this information, I would say pay attention to, or I should say, break them down into categories. So you're going to have a category of what we call acquired, and then a category of congenital. Acquired are going to be things that, so we all know anemias are going to be a decrease in red blood cell count. Okay, so my major thing that I want you to know, and I keep these test questions very plain and simple, making sure you know the title of the anemia and what is the lack, because no matter what anemia the patient has, there's some sort of deficiency. Okay, so it is important to know what is a deficiency, what is a deficit. Are they missing iron? Are they missing B12? Are they missing whatever it is? Okay, so we want to make sure we know what they're missing. So under your acquired anemia column, you should definitely have those that are associated with vitamin deficiencies, okay, and there's a few. We also have an anemia that's due to a lack of blood loss, okay, so if your patient is hemorrhaging and they're bleeding out, they have an anemia from that. We also have an anemia that's associated with acute renal failure, okay, and I think we discussed this maybe week 1, okay, as a practice question for understanding erythropoietin. Erythropoietin is secreted by the kidneys, okay, so you guys get the idea, okay, and so those are the ones, and maybe 1 or 2 others. Congenital anemias are going to be something that a patient is born with. So this patient is born with a lack of whatever it may be, okay. Now, I'm going to go through this list really quickly for the sake of time. I don't have time to write it all down. If you can get it down quickly, you know, that'd be great. The first congenital disorder that comes to mind is sickle-cell anemia. I'm sorry. Oh, okay. Okay, so sickle cell anemia, thalassemia, glucose 6-phosphate dehydrogenase deficiency. I know that's a long name, but you can abbreviate it G6DP something, whatever. Yeah, you get the idea. What else is congenital? Aplastic anemia is one of those that kind of can piggyback either or. It just depends on the cause, okay? And sometimes you have conditions like that where sometimes people are born with it, but then sometimes it can also be acquired. I can't think of anything else at the moment, but you'll notice in the PowerPoint which ones, you know, people are born with missing something, okay? And that falls into that category. So again, if you can categorize that, that will help you a lot for 13. Okay, and then we have 3 polycythemias that are just kind of focused on those 3, and that's it. Okay. Now for chapter 14, I'm just wrapping up, but you can come on in. So for chapter 14, please focus on just what I put in that outline, okay? Because I'll tell you a secret. I noticed that even in my test bank, and when I look at materials for, you know, NCLEX-Al questions and things like that, there's not a lot of questions on blood coagulation disorders. And so I talked to one of the nursing instructors and I said, you know, I have a hard time finding, you know, a lot of questions about blood coagulation disorders. And I said, are they as common? And she said, no. So what'll happen is this. When we talk about blood coagulation disorders, it's not a common type of condition in the sense where you're going to see a lot of people that have hereditary blood coagulation disorders. So when we think of hereditary blood coagulation disorders, we think of people missing a certain factor, okay, that they're born with. Those are not the most common type you're going to see. And again, just to make a long story short, I'm not going to have tons of questions with 14 because there's not a lot of, it's not as common as we think it is. So saying that, I did put in particular to pay attention to hemophilia because they do believe if it is a, you know, congenital disorder, to pay attention to that one. Also, there are some others that are listed there. Now, outside of that, I want you to please pay attention to all of the acquired things, such as patients having blood coagulation disorders because of too much aspirin or, you know, a pre-existing condition like liver disease or cancer or things like that, okay? I do also have test questions on the lab test, not the numbers, but in a sense of knowing what the lab tests are testing for. Okay, so I do go over that in the video. So just make sure you pay attention to the blood clotting assessment and know what it's used for and how that correlates to the coagulation cascade. Okay, and that should sound familiar to you from physiology. Okay. And just to also make you aware, I'm not going to have questions with the whole coagulation cascade, so we're not going to, you know, get crazy with that. But just making sure we understand at least the common pathway, intrinsic, extrinsic, and which labs correlate with what part we're testing for. And the reason why that's important is because if a person has a bleeding issue, they come to you, they're bleeding, they can't stop the blood, okay, you need to figure out, okay, why? Do they have a bleeding issue where they don't have enough factor? Is it maybe the vessels are not constricting enough, or do they not have enough platelets? So your job as a nurse is kind of figure out what's happening. When the labs are performed, the labs are particular to see if the patient has enough platelets, do they have enough of certain factors, okay? And that's where those assessments come from. So I'll go over that in the video. And I think that was it. Okay. Chapter 15, same thing. Focus on just what I put in that outline. Okay, and I was very specific with that. Okay, so arterial venous blockage, embolism versus thrombosis, and then I put a list of 5 different topics. So we should know everything about aneurysms, DVT, varicose veins, okay, which I'm sure we've all heard of at some point about these things. And then Berger's disease, Raynaud syndrome, and then lymphedema. Okay, and what you need to know from that, know the title of the topic, what's happening with the condition, so what is it that's happening in the pathogenesis, okay, so if the vessel is too dilated or whatever's happening, okay, so we should know what's happening, and signs and symptoms, and that's about it. Just to make you aware, I don't know if I said this to you before, but I do not put a lot of treatment questions on my test. If I do put a treatment question on the test, it is very straightforward, in a sense where if the patient is missing this, give them this. If they're missing iron, you give them iron, okay? I do not put a lot of treatment questions on my test because with patho, we want to focus on pathogenesis. Treatment and management, you're gonna have that the next, how long you can program? 2 more years? For the next 2 years, okay? So we don't have to focus so much on that at this moment, but just definitely understanding the disease process, okay? Yes.
When you say outlines, is it just the PowerPoints or where are the outlines on?
The outline I provided in class. So there was the outline for week 2, so the one that I typed up.
Okay.
So that one, just pay attention to exactly what I typed there,
Okay.
okay? And you guys should be good to go. So my time is getting to the end here. Does anyone have any particular questions of any particular topics? I tried to give a brief overview, as you can see, with the 5 chapters, but does anyone have any particular questions? And I can entertain that now, yes.
For the lab test, like just for example, for like the CBC, you just want us to know that it identifies anemia? Or how would you?
So, don't worry, don't get so caught up with that, because I don't have test questions with, okay, anemias, we need a CBC.
Okay.
We're going to use that information more so for our in-class activities.
Okay.
I have an in-class activity regarding that.
So focus more so on like the disorder and then what
Yes.
lab test is used for it?
Right.
Okay.
So the only one that I do get in detail with, and I'll show you, so if you go to instructor blog and pull up the clinical reference guide with the labs, the only one that I explain, well, I shouldn't say the only one, because I have different ones that I explain from week to week. But let me just show you an example. If I can find it. Oh, here it is. Okay. So blood clotting assessment. So this panel correlates with blood clotting disorders. Okay. So in the video, you'll notice that I'm going to break this down and explain what the INR is, why they're testing for that, what the PTTT is, and what they're testing for that, and the APT. So I'll explain that in the video as to why those tests are performed. And that's all I need you to know.
Okay.
We don't have to go into the numbers here and figure out if the patient has a history and all that type of stuff. But I just want you to be aware of what the assessment is used for.
Okay.
Okay. And we're going to get into the numbers in class activities, because I like to use that more for like our clinical, assignments and hands-on. Okay. So any other questions? Yes.
I kind of a question, not basically on this, but I just wanted to clarify. For the midterm, is it going to be on all chapters leading up to the midterm, or is the midterm going to be specific chapters?
No, the midterm is cumulative for the first half of the course.
Okay.
And then the final exam is cumulative for the entire course.
For the entire course?
Yeah.
Okay. I just wanted to make sure.
Okay. Okay, so for those of you who are here for the 3 p.m. tutoring, thank you very much. I am now going to switch, 2 p.m., excuse me. Now I'm going to switch over to the 3 p.m. tutoring, which is going to cover chapters 1, 2, 4, and 7 for the Wednesday's class, so they can get prepared for their quiz later, okay? So you can feel free to stay if you like, if you want to listen to it again. But I have to switch over now. And just keep in mind, I will have tutoring tomorrow evening, YouTube live, and I will post that information, okay, tomorrow morning.
Is it going to be the same time, or do you think it'll be different time?
No, it's the same time each week.
Okay.
Same time each week, Thursday evening at 8 p.m. And I'll have that information posted, okay, so I'll post it in the morning for you, and just be ready to click on it at 8 p.m. That's a good time to have your questions ready. So like today, I just kind of did a quick little overview with everything. Now when you go home tonight, this will be time to kind of digest things and then bring your questions tomorrow evening. Okay? You're welcome. Okay. Wednesday people. Oh, you know what? I forgot to tell everyone. Sign in, because we do keep track of who comes to tutoring. So if you didn't get a chance to sign in, please do that. The student services, they do have a test anxiety workshop. So if you're interested in that, and they do also have some other information for test taking skills.
Do we sign in again with the different time?
No,
or
no,
one
no,
time
it's
sign?
okay.
Okay.
Yeah, if you just signed it once.
Thank
that's
you.
Oh.
Do we need to sign out as well?
No, you don't need to sign out. It's okay. Just sign in.
So how are you?
I'm doing good. Doing good. Just a little tired, but I'm good.
Ready for the 6
Yes. The first
I'm all scared
test.
over here like.
No, you'll be fine. Everyone did well. It's just the first quiz. You'll be fine.
The quizzes are worth 50 points each?
They're 60.
Oh.
That is right here.
Oh, I'm sorry. I do have another page. I'm sorry.
And there's going to be how many? So a final and a midterm, and then the first, so there's going to be 7 of them.
I'm sorry.
7 quizzes.
Yes. And then we have a final midterm.
So our signature assignment is going to be a case study. Do you want us to like do an essay or like respond to it, or?
No, I'm going to go over that because it's a whole description. You have to design a case study and also a nursing care plan. So it's like a whole project. I will explain that probably starting next week. So for those of you who want to get started with it, it's not due until week 6 of the term. Okay, so I want to get started because it is 3 p.m. and I do need to leave this room by 4 p.m. because there's another class coming in here. So just to make you aware, for those of you who are in the Wednesday section today, getting ready for your quiz that's going to start later this evening, this review that I'm doing, and you're probably going to hear it, well, you will hear it again, because I do a review in the class as well. So we review kind of like a teach back review session. So you'll hear the information twice. Okay, so yeah, you should be even better. Okay, so chapter 1 was a chapter that just focused on patho terms and just understanding the terms, definitions, examples. How do we take this term and put it in an example type question? Okay, so the focus here is just making sure we memorize the terms, basically. Okay. To get started, the framework of pathophysiology really is looking at the terms etiology, risk factors, pathogenesis, signs, symptoms. We didn't have treatment incorporated in there, but that's basically, the framework. It is extremely important to understand the difference between etiology versus a risk factor. An etiology is a known cause for a disease, whereas a risk factor is the likelihood of a person developing that disease. A big difference. The reason why it is a big difference is because a known etiology is something that we know for sure. In most cases, it would have to be tested or measured in order for us to say that we know for sure. So we can't say that, you're eating your bag of chips is going to give you GERD. Okay, we don't know that, but not to pick on you with your chips. But we don't know that for sure. But unless there's some sort of, tests that have been performed, and they went through studies and say, okay, well, these bag of hot Cheetos is going to give this person this. Okay, so that is what we call the difference between a risk factor and an etiology. Okay, risk factors, I think we also found out that it breaks down into modifiable and non-modifiable. Important to know this clinically. For sure, it's going to come up in nursing. Because the modifiable risk factors are what things you'll be focusing on with your patient teaching, okay, and home care, things like that. Whereas the non-modifiable things, it's nothing we can do, okay. The difference between a sign and a symptom is also important to know, because this correlates to, and we had this as our discussion board question, it correlates to how you do your patient charting, okay. So a sign is something that is measured or observed, something that the clinician, okay, can figure out. Whereas a symptom is what the patient states or what the patient feels. There is a difference, even though sometimes these terms, kind of people overlap them, but there is a difference, okay. Just to also help you, there are some terms that sometimes people get a little confused with. And so let's start with iatrogenic. Iatrogenic sometimes can be a little confused with sequela for some individuals. And so iatrogenic is a situation where we develop a condition or an illness secondary to some sort of treatment. In most cases, it's usually medication or maybe some sort of procedure or whatever has occurred. Now this person developed a secondary illness because of it. It wasn't intended to happen. We didn't want that to occur, but it did. Top of the list for examples for this are definitely medications. And I put this on the top of the list because there's so many side effects from medication. No matter what medication, it may have something. Okay, and I think we know this. And this becomes very important to you guys with your practice in nursing because a medication is provided. You provide a medication, however, that medication may have a side effect that now develops something else, which now you have to provide another type of medication for the secondary thing, okay? And then this now leads to the cascade of events that occur, okay? And especially as patients get older and more complicated types of conditions and chronic things that develop. And for those of you who work with geriatric patients, if you ever see this, sometimes they come in with a bag of 20 pills, okay? Not that they have 20 different conditions occurring, that they need 20 different medications, but the reason why is because there's side effects, okay, of things that they're also trying to manage. So you get the idea. Okay, now, sequela. Sequela is when we now have one condition that develops into something else, and something else, and something else. Okay, then it just keeps rolling and rolling. Very good example that you guys will encounter, unfortunately, infections and how localized infections can lead to sepsis. Okay, so I'll start there. Let's say, for example, you have a patient, they're in the hospital or whatever situation. They develop an infection right at the IV site. Okay, so let's say the IV's there. Let's say the IV for some reason wasn't changed in a timely fashion. Okay, or some sort of issue. We don't want to say the nurse was wrong, but something happened. Okay, and what happens here is that now this patient develops a localized infection. Well, that's not a good place to have a localized infection because we have an open line, which means now, here we go, right to the bloodstream. So now this patient is going to develop not only a localized infection, now they have a systemic infection. This systemic infection leads to sepsis, and let's say the sepsis gets out of control and leads to septic shock and organ failure and the whole thing, okay? So you get the idea. This is what we call a sequela. And we'll talk about sepsis later on because that is something, ooh-wee, it's a big topic, okay? And even so big of a topic that some hospitals do have a whole sepsis team of nurses that just focus on that because it really can lead to a sequela of things. Okay, so another topic that sometimes people are a little confused is subclinical. Subclinical means this. Let's say, for example, I used to have thyroid issues. So let's say, for example, someone has thyroid condition. They have a thyroid condition, they're diagnosed with it, they're given medication, the medication is helping, and they're managed at this point, and they're still going around, you know, doing their thing. They're still diagnosed with thyroid disease, but it's managed. This is what we call subclinical, meaning that the disease process is well established, but the patient may not be as symptomatic at that moment. It may not be, you know, a detrimental thing at that moment, but they're in what we call a subclinical stage. Does that make sense?
So they're functioning.
They're functioning, yes. They're functioning, it's managed, it's under control.
Like high blood pressure.
Like high blood pressure. High blood pressure, diabetes, sometimes patients that are diabetic, they're, on top of their thing with their meds and nutrition and, everything's under control. They're still diagnosed as being diabetic, even if it's managed at the moment. They still have that title, but this is what we call subclinical. Okay. Can't think what else here. Oh, and I need to look at my time to make sure I'm not going to. Okay, so endemic, pandemic, those are pretty straightforward. Let me just go here. Levels of prevention, we have primary, primary, secondary, tertiary. Primary is altering susceptibility and reducing exposure to persons, which means these individuals will, we're trying to prevent a condition happening. Okay, so the important thing here is with primary, the condition or the disease has not started yet. When we get to secondary and tertiary, it's possibly on its way or starting or has started. So here, the disease hasn't started yet, so we're trying to prevent it from happening. So that can be vaccinations, definitely patient education. Okay, so providing a patient education on safe sex or whatever it may be, so to prevent them from developing something. Okay, when we get to secondary, this is going to be more like also preventative, but in a sense where this falls under like routine blood work or annual physical exams, prostate checks, mammograms, things like that. Even if a patient is going in for like a follow-up appointment, so like managing the condition. Okay, so even if a medication was prescribed, this is still considered secondary because they're still managing at that point. Tertiary is still management as well, and so this is where it gets a little confusing with overlapping. Management is also happening at tertiary, but the management here is going to be a continuation, but now we're pulling in other healthcare providers. So maybe this patient needs a consult with a social worker. Maybe they need OT or PT to kind of get them now on the rehab part, to move on. So that's that. Is everyone comfortable with that? Okay. Any questions with chapter 1? And like I said, if you don't get it now, don't worry, we're going to go over it again. Okay, at 5:30. So, chapter 2, this chapter, I'm going to tell you what I have for questions here are extremely straightforward in the sense where you should know this, this, and this. Okay, so let me get started. It is important to know the difference in the terminology or definition as homeostasis versus allostasis. Okay, and let me go into allostasis because sometimes people are not quite sure what that means. Homeostasis is when we have a particular disease, or not disease, I'm sorry, my brain is. Homeostasis is when the body is functioning at an ideal set point. Okay, everything's functioning, everything's flowing, everything's good to go. Allostasis is when the body recognizes that we're out of that homeostasis and now we need to bring it back. Okay, so the example I gave on Monday was Super Bowl. Okay, so say you went to your Super Bowl party and had a little too much to drink, a little too much to eat. Okay, so let's say all the drinking at the Super Bowl party, too much beer. What's going to happen now? The body recognizes, okay, you did a little too much. So what's going to happen is that the liver is going to take all of those toxins from the beer and alcohol that you had at the party and now turn that into a non-toxic substance. Okay. Now it's going to take all the pizza and wings and, you know, desserts that you had at the party as well. And now your glucose levels that are in your bloodstream are a little higher. And so now the body will take some of that glucose and store it for later, okay, into the liver and muscle cells. So this is what we call allostasis. The body has a certain set points, or I should say set points, but certain functions, mechanisms put in place to balance things out. That's how you want to look at allostasis. Okay. Does that help? Okay. Now, stressors. We have physical, chemical, emotional. And just basically that. Okay. We'll get into more detail with examples later, okay, in class. And now, everything else in that PowerPoint, and I'm going to go down the list. So, number one, you should know Seeley's General Adaptation Syndrome. So, we should know, in a sense, the order, such as the stage, or I should say the alarm stage, stage of resistance, and stage of exhaustion. Okay, so that's the order. So, the Seeley's General Adaptation Syndrome. This is how the body adapts to whatever stressor is happening. The next category we should know is basically knowing everything that's secreted during the stress response. And not that they're all secreted at the same time, but just knowing what's being secreted. Okay, so let me start off with epinephrine, norepinephrine. We know those are secreted. Cortisol, aldosterone, yes. Endorphins and enkephalins. And then we also have oxytocin, prolactin, growth hormone, and then immune cytokines. Okay, those are the list of things. The reason why I want you to know the list of those items, because we need to be able to differentiate. It's not everything, okay, that's going to help with the stress response. Okay, that's being secreted. So erythropoietin doesn't help with the stress response. Okay, so you know we need to know what is helping and what's not. Okay, and that sums up chapter 2. Okay, if you know that information, you should be good to go. As you know, chapter 2 wasn't a lot of information, so I don't have a lot of questions with chapter 2. Okay, so chapter 4. Yes.
So for those hormones that we need to know, basically we just need to know that it releases or secretes when stress applied, or
Yeah, so just know what's secreted. You should also know like the action as well. So, and I should say also the system that it correlates with. So I'll break it down for you. The nervous system secretes epinephrine and norepinephrine. We know that their purpose is to play a part in the fight or flight response. Okay, so I think we went over this in anatomy. Endorphins and enkephalins also are secreted from the nervous system. Their purpose is to help raise the body's pain threshold. So if you have a trauma, like a physical trauma, let's say you stub your toe or you fall down, okay, your body sends those things out to raise the pain threshold, okay. Endocrine, for the endocrine system, we have aldosterone and cortisol. They do help support the immune system, and as well as other things. And then we have prolactin, oxytocin. We know their normal functions from the endocrine system as far as breast milk and things like that. But also, they support the immune system as well. And then growth hormone also supports the immune system. And then from the immune system, we secrete immune cytokines, which are basically chemical mediators, as we know, that brings more white blood cells to the area to further support the immune system. Okay. So a lot of this really is supporting the immune system in overall. Okay. because your immune system is very important when we have different types of stressors, and you want a nice, healthy, strong immune system, because if you don't have that, that's going to lead to disease. Okay, disease process. Okay, we're comfortable with that. Okay, so chapter 4, and let me write it down like this. I think I'm doing okay. Time. Yeah, Dr. Youssef has a class in here at 4, so. Okay, so with chapter 4, we really focused on cell injury. The entire title is aging and death as well. But with cell injury, I would say the best thing to do here is break it down to reversible and irreversible. Okay, cell injuries are broken down into these 2 categories because for not only just test purposes, but we should know which ones are reversible, which ones are irreversible. Okay, because the ones that are irreversible, you have to, treat it as such, and that's it. It can't reverse back. But the ones that are reversible also should be managed. Okay, because it can reverse back to normal. Now, under this topic, these 2 topics, and I'm just going to write down the topics under the categories, okay? We have the first one, hydrophobic swelling. Make sure you know everything about hydrophobic swelling, okay? Yes. So what's happening on the cell membrane, the sodium-potassium pumps, water coming in, the cell gets bigger, the whole thing. Okay, we should know that whole process. The next category are intracellular accumulations. So these are going to be items that enter inside the cell that should not be there, or items that are in excess inside the cell that should not be there. So there's extra things sitting inside the cell. So intracellular accumulations. So this can be anything from, let's say, one major example that was in the PowerPoint was faulty metabolism. So if something is not breaking down appropriately, so let's say the lysosomes aren't working properly and they're not breaking down certain products, and so now we have, excess waste just kind of sitting there, okay, or whatever it may be. So now it accumulates inside the cell, okay, and cause that type of injury. Your PowerPoint also went into other subcategories under this, like if an enzyme is lacking, or if there's altered genetic information and toxins getting in, and all different types. So there were I think 4 different subcategories under this. Okay, but in essence, I think we get the big picture. Okay, with intracellular accumulations. Okay, so now the next category was basically cellular adaptations. Now, under cellular adaptations, we have atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia I'm putting over here. And I'll explain right now. So when we have these items here, these are cellular adaptations that are considered reversible, because if you remove the stimulus, it can reverse back to normal. Okay. So if the person stops smoking, the metaplasia that's going from one cell type to the next, okay, can revert back to normal, okay? And just keep in mind, let me just explain this in a little more detail so we can understand. When a person has a metaplasia, let's use the airway, so in smoking, normally the epithelium is columnar. As a person smoking, that columnar can turn to a squamous. We know it's a squamous, we can see that on the slide, okay? It's from one cell type to another. It's still not normal because we should not have squamous there, okay? But if they stop smoking, it can still revert back to normal. So we're sort of okay here. Here, if that person's smoking, and then now we take a sample, look at the cells, and instead of it being columnar and looking like something else next to it, now what's looking next to it looks like a total disarray, and we have no idea what it is. That is now considered dysplasia, considered preneoplastic, and it is irreversible at that point. Because even if they stop smoking, it's not going to reverse back to normal. Does that make sense? So the only way to reverse that is actually through treatment or management. So you have to remove those cells or whatever they're going to do. This piece is very important to know, and I'm also going to add into this as a side note, because it came up in chapter 7, the term anaplasia. So anaplasia is a term that's used when we're describing the histology when this person is being diagnosed with cancer, basically. So let's say here, you look at the histology slide, you can see columnar, we know, okay, it came from the blurb, so we see the columnar, and then you see something that's a disarray. But now, if you're using the term anaplasia, they're looking at the slide, they know it came from the airway, but when they look at the slide, it looks like a totally different piece of tissue, okay? And they can't see any little columnar, they can't see much of what's going on here. So this is now a higher degree of disarray of what we call anaplasia. Does that help? Because I know this term came up in chapter 7, so I just wanted to clear that up. Now, I'm definitely going to go into this in a lot of detail when class starts, because the necrosis and gangrene information was in the PowerPoint, or I should say in the video, but not the PowerPoint, okay? And so I do want to clarify, everything that was there. So, just to kind of sum this up, the term necrosis and gangrene are used to explain cell and tissue death. Okay, I think that's one of the first things that pops in your head when you think of necrosis or gangrene. Cell death, tissue death. Most of the times when we are explaining this, the best definition to explain it is that it's due to a lack of blood supply. Okay? This is due to a lack of blood supply, and in particular oxygenated blood, and also sometimes this can be due to toxicity as well. However, when we say it's due to toxicity, even if a person has an infection or a toxin in the body, I want you to always know that there's also going to be a lack of blood supply with that. So it's not that it's just infection and no blood supply, or I should say in there having good blood supply. There's always going to be a lack of blood supply that's leading to this situation. Okay. For those of you who read the textbook, it went into detail with explaining what's happening on the cell membrane, and that there's too much calcium getting in, causing the cell to rupture. Okay. I don't get that detailed as far as test questions, knowing the calcium channels and things like that. But what I do want you to be aware is that once the cell membrane ruptures, there's no turning back, okay, which is why it's irreversible. There's no surgery, medication, nothing you can do to bring that cell back together. And if the cell bursts, this is what happens. The contents of the cell now are spilling out into the tissue space, okay, and out into the neighboring areas, which is why when you have necrotic tissue, it's discolored, it has a different texture, it can smell, okay? And just to make you aware, and this comes up in chapter 7, sometimes tumors can become necrotic as well when patients have cancer. And if you ever have an opportunity to, be in a surgical room when they're going in to remove that, it can smell really bad. Okay, so these changes will happen because of that cell and tissue death, okay, that's occurring. So, so that's that. Now, necrosis, now the difference with necrosis and gangrene, okay, what is the difference? Well, these terms overlap. I don't get crazy with this as far as test questions in the sense where I will never put a test question where you would have necrosis and gangrene in the same sentence and answers, okay, where you have to figure out, oh, is it necrosis, is it gangrene, okay, because they overlap. So your test questions are either going to be all necrosis or all gangrene, okay. In most cases, I just really focus on necrosis, okay. And clinically, and those of you who work in the field probably know this, I don't even think they have a different diagnosis code for it. I think it's just one diagnosis code for necrosis gangrene. Okay, so we don't have to get crazy with that. However, I do want you to know the 4 different subtypes, okay, that fall under this or this category. So the first one we have is coagulative. Coagulative necrosis, just to kind of sum this up, it is due to a lack of blood supply. Most common location is extremities, hands and feet, because that's the furthest place, blood circulates to. And when this occurs, the tissue, when it dies, it becomes very dry, hard, it can be discolored, it'll turn black. And usually you can see a line of demarcation between healthy tissue and dead tissue. Okay. Yeah, that's that. Liquefactive necrosis is just what it says in its title. It's liquefied. So the tissue will actually look as if someone it melted or something. Like it looks like it's liquid. This is more common in internal organs, brain tissue, the intestines, wherever, okay. It's a little more liquefied because of the environment. Now, can you have a liquefactive necrosis externally on the body? Yes, it is a possibility. I've seen pictures of it, okay. So sometimes people can have a liquefactive necrosis on the skin, but in most cases it is internal. Okay, so for internal type things. Caseous necrosis, when you see this term, always look at it as secondary to TB. Okay, when tuberculosis occurs, and let's say it becomes very complicated, leading to this type of necrosis, caseous necrosis attacks the lung tissue, and they describe this as a blue cheese appearance. So in a sense where it becomes white, so it doesn't turn black, it looks white. And the texture of it is also extremely soft and brittle. So if you were to touch it, it just kind of like breaks apart, okay. Sometimes I wish we had a pathology lab so we can, not that you want to touch it, but to actually see these things, what it looks like. And fat necrosis. Fat necrosis, in your textbook, they say this can be secondary to pancreatitis, okay, when that occurs. And this can also develop secondary to breast surgeries. So when women have breast augmentations or even possibly reductions, and let's say there's an infection that develops, and the reason why is because the breast tissue has the most adipose tissue, most fat cells. So this is what happens. Basically, the adipose cells burst. Cell membrane ruptures. And when that ruptures, now we're left with, like, they call it a soapy appearance to the tissue or the organ. And basically, we know what fat looks like. And so it's just like kind of clumps of yellow, you know, appearance to it. And so that's that. Dry gangrene correlates with coagulate necrosis. Wet gangrene correlates with liquefactive. And then I believe I did discuss in the video gas gangrene. And that's kind of in a class by itself. It's just due to Clostridium, and it attacks the muscle tissue. And that's about it. But if you focus on this, you'll be fine. I think I may have one question with that area. So you should be fine. So any questions with chapter 4? Oh, I'm sorry. You had a question? Oh. So chapter 7, with this chapter, I need to know everything. Okay. So let me tell you what we should omit, and I believe I explained this last week. So in the video, and this is one of the reasons why I need to update my videos. So in the video, it was discussed to look at 7.7 and table 7.6, 7.7, which give the list of tumor markers. Just keep in mind, I am not testing you on tumor markers, so you do not need to memorize that information, which is table 7.6 and 7.7. You do not need to memorize that, okay? We will incorporate that with the class activity tonight, but you don't need to memorize it for the test. However, I did want you to focus on table 7.1 and 7.2. 7.1 just gave us a list of different characteristics for benign malignant tumors. Even though we had that information in the PowerPoint, but it just gave us some additional things. And then 7.2, I also don't need you to memorize each and every item there, but it was basically just to get you familiar with how the suffix oma, carcinoma, and sarcoma is used. Okay, so that was the purpose of that. So let me just start from the beginning. Benign and malignant tumors, very important to know the characteristics. I guarantee you this will probably be some sort of test question. It's extremely important to know this, not only for test purposes, but forever and ever. Benign tumors versus malignant tumors do have very different characteristics, very different. When it comes to how we name cancers using the oma, the carcinoma, sarcoma, the confusion for some people lies where when they look at carcinoma and sarcoma, they say, oh, it has oma in it. Don't get confused. If you see carcinoma, the entire thing is a suffix. Carcinoma, sarcoma, the entire thing is a suffix. So what you have here is the root word or the organ and then the suffix behind it. So you can have, lung carcinoma, okay, or what have you. So you have the organ and then the suffix. There are some exceptions to the rule, which is extremely important to know this. Lymphoma, okay, for sure. It ends in oma, but it's still considered a malignancy. And I'll tell you why in a second. Leukemia has an entire different name, okay, and that's also considered a malignancy. Now, some of you were here with the other tutoring and heard me go over leukemias and lymphomas. And the situation here is this. In chapter 7, we discussed that once a person has a malignant cancer, that malignant cancer has an opportunity to spread, okay? And that term is called metastasis. Metastasis happens through either blood or lymphatic channels. That's how it spreads. It escapes through the bloodstream or it escapes through the lymphatic stream. So, if a patient has a primary cancer in the bloodstream or the lymphatic stream, we never look at that and say, oh, that's benign. It is always treated as a malignancy because we know that's the same route that cancer can spread. So we have no idea how it's behaving, what's going on, okay? So it is always looked at as a malignancy. Now, obviously, they have different stages, but, you know, it is categorized as a malignancy. That's very important to know. So going back to what I was explaining, ulma is the exception to the rule, lymphoma. Lymphoma is the exception to the rule. Your book also has hepatoma as the exception to the rule, and there's something else I can't remember. Melanoma. Melanoma. I think we all know melanoma is malignant, and so it ends in oma, but it's still considered a malignancy. Okay. So where are we now? Tumor markers. Tumor markers are extremely, extremely important to understand why we use them or why we test for tumor markers. Now again, I don't need you to memorize each and every one. You don't have to get into the labs and all of that. But why are they even tested for in the first place? Well, the reason why we test for a tumor marker lets us know what is the parent cancer or the primary cancer. Where did the cancer start? So let's say you have a patient that comes to you and this is your first time seeing them, and let's say they have a scan done and you see multiple tumor locations all over the body, okay? Well, that's not telling you where the tumor or where the cancer started. So now we have to go deeper, do blood work, do special studies, take a biopsy at different places depending on, you know, where they feel they need to take a biopsy from. And that information is going to provide you with information, what we call a tumor marker. A tumor marker can be an antigen, it can be an antibody, it can be certain markers on the cell surface that lets us know that that's where that primary cancer started. Does that make sense? Okay, so we need to make sure we know why or the purpose of testing for a tumor marker. And it also helps the oncologist too, because some cancers do have certain behaviors. So they'll know, okay, well, if this patient has prostate cancer, well, the next place it may metastasize maybe is the pelvic bone or the femur. So they have an idea to how to track the tumor activity if certain tumors may start to pop up. Okay, very, very important with management of cancer to know the tumor markers. Yes.
So when you said, do the tumors look like a certain cell? Is that?
No, so basically the marker is something that that tumor is going to secrete, almost. That's going to let the body know this is where it started. So you know how our immune system is very smart and it knows when there's things that are foreign, and, you know, so it's almost the same thing as like when the body knows that cancer start, it's going to give us a marker. It's going to give that initial marker to say, okay, here's the breast cancer, here's the prostate cancer, here's the pancreatic cancer. So it gives that marker immediately. Well, I shouldn't say immediately, but you know, it gives that marker. So that way we're not confused to say, oh, well, which cancer is it? Is it pancreatic, even though they now have, you know, metastasis in the bone, maybe it's an osteosarcoma. So we don't get confused. The body will always put a marker to let the immune system know that this is where the primary cancer started. It's more of an immune response type of thing. Like it's almost like an immune marker. So the body knows. The body knows what's happening. It's very interesting because the human body is very smart. So, you know, at least on the medical end, we know where that cancer started. So then we know how to, you know, take it from there. Okay. The next thing, another way to diagnose is grading and staging. Okay. Grading is looking at the histology of the cells. Okay, so we take a biopsy. I think we all know that biopsies are usually probably the most definitive way of diagnosing cancer. The biopsy lets us know possibly if the marker is there, okay, like we just discussed, or the biopsy lets us look at the cells and we can see that it's a total, I erased it, but it's a total disarray leading us to an anaplasia. Okay, so that's the purpose of the biopsy. Okay, we need to look at the cells and see what's going on. So that whole process is what we call grading. That's a grading procedure. Staging is now looking at the extent of the tumor spread. So this is where, you know, the doctors will sit down and look and say, okay, well, pancreatic cancer's here. Okay, however, now this patient has, you know, some metastasis to the liver and the femur or whatever. Okay, so now we're looking at what are the extra tumors that are now popping up. Okay, so the more tumors the patient has, obviously the more aggressive this is. So the more metastasis, the higher they're going to go in the stage. So a stage 1 would be like more localized to one area. Stage 2, the tumor may be spreading to lymphatic or blood, and then a stage 3 or 4, multiple tumor locations, you know, throughout the body. Bone marrow suppression is extremely, extremely important to know. When we talk about signs and symptoms of cancer, it's not exactly cookie cutter. However, we do have an idea as to what's going to happen, okay? So one thing that I want you to know is that when a patient has cancer, I think we all have an understanding that the immune system is going to start to decline, okay? They're going to have a decrease in platelets, possibly, a decrease in red blood cells, a decrease in white blood cells. And this is the piece that's important to know. If this patient has a decrease in red blood cells, they can lead to an anemia, which means that they're going to have signs and symptoms of that. Okay. If the patient now has decreased platelets, now they may have issues with clotting the blood. They maybe bleed out a little more. So now that's something you have to manage. If the patient has a decrease in white blood cells, they are definitely going to be prone to infections, which is also something as nurses you'll have to manage. And the reason why this is so important to understand in your field is because the patient's going to have cancer. So that's one thing that has to be taken care of. But then now they're going to have these secondary conditions, okay, or if you want to look at it as sequelas, so to speak, okay. Now these secondary things that are going to happen that are now things that you have to address, okay. We have to make sure that, you know, their infections are under control so it doesn't get out of control, and so things like that. Something else I wanted to say. When it comes to treatment, look at my time. I'll say, let me just finish this up and then I'll stop. Cancer treatment, we have chemo, radiation, surgery, so I'm going to just go there because those are kind of like the most common treatments that are provided. And then bone marrow transplant and some immunotherapies and things. Those are like more specific to certain types of cancers, okay? Now, when we say surgery, they're removing the tumor, removing whatever it is, okay? So that's easy to understand. Chemotherapy attacks rapidly dividing cancer cells. Cancer cells rapidly divide. Cancer cells, I think we know, have an idea that they have a high rate of mitosis, which is one of the reasons why cancer treatment and cancer research is difficult to handle that area. Okay, can we stop mitosis? No, it's very difficult for us to stop mitosis. And especially with and the thing with mitosis is we can't stop it just with cancer and not everything else. Okay, so that's the issue. So when we talk about chemotherapy, it attacks most rapidly dividing cancer cells to get rid of that, which is great. The problem is we know chemotherapy also attacks most rapidly dividing normal cells, such as blood and epithelium. So when patients have hair loss, skin lesions, and even the bone marrow suppression is a double whammy, because the bone marrow suppression is going to happen just from the cancer itself, and it's also going to happen when they have chemotherapy. So it's a double hit, okay? And so this is the issue why they're extremely immune compromised, okay, when they're undergoing chemotherapy. And then radiation therapy is there to attack, to shrink the blood vessels surrounding the tumor, to shrink the tumor, hopefully. And then I'm just going to stop with my explanation there. Does anyone have any particular questions? No? Okay. Well, hopefully that helped you guys. Keep in mind, I will see you at 5:30. We will be doing another review just like this right before the quiz. Okay, and I'm going to stop this recording.
Thank you.